So with this, I think we'll move straight into our public feedback and comments period. And I know that there's one member of the public who signed up to give comments. That is Roy Wittes. Is there anyone else who, in the audience who is interested in giving public comment? Okay, so Roy, go ahead.
Thank you. Thank you for the opportunity. I come to make these comments with a couple of pieces of experience which perhaps are different to other people in the audience. Not only was I involved in designing a comparison system, I spent 3.5 to 4 years at the Institute of Medicine, longer ago than I care to be honest about, actually pulling together the disease burden data domestically for the US and internationally across about 40 diseases, and pulling together predictions of vaccine development across about 50 vaccine candidates. Those committees, or that committee, also looked and polled a lot of people about value judgment. So that's one set of experience. The other set of experience is basically at the National Vaccine Program Office in the mid-90s, when the resources were very short, as they are now. And we tried to start an initial activity there looking at prioritizing combination vaccines. It didn't go very far, but it gave me experience of the need to put your resources, to allocate them very carefully. I think the fundamental question that this committee and National Vaccine Program Office have to answer is, what is the practicality and what is the added value of the enormous effort required to use this system to calculate individual scores on those issues beyond public health benefit and the associated costs. Putting it another way, the question is, how do these individual scores actually support decision-making? At the moment, the scores, as far as I can see, derive from a number of inputs. People can include up to 29 attributes. We've heard from Chris Murray that these 29 attributes are not exhaustive, and they're conceptually a fairly mixed bag. People will have to make choices about ranking these attributes. They may rank them differently, even if they understand them. They may also interpret them differently, which may affect the ranking. The scores are ultimately also affected by this rank-centroid approach, which, again, Chris Murray has indicated that he doesn't think is necessarily appropriate. The committee says that it may go to being allocating weights according to people's individual judgments. Whatever those weights are, they are arbitrary and independent of ultimate health benefit. The other things that go into the scores are obviously individual subjective values, which clearly are different, but those values, those decisions will also be affected by the way that they interpret the criteria. I've submitted very long written comments on the fact that virtually every criteria that the committee has identified can be interpreted differently, and it's very difficult for individuals to hold in their minds one complex set of things like disease eradication possibilities and weigh it against another criterion. So ranking is very difficult, particularly if you're interpreting things differently. I think it's important to try and think about how you go from individual scores to what the National Vaccine Program Office needs, which is an institutional system. There are many, many reasons why individual scores differ, And we won't really be able to get at the issues that affect individual scores by looking at a set of numbers that actually look like the numbers that come out of the lottery system, 50, 43, 20, and 19, and 8. Those numbers really don't tell us anything because they have no units. There's no consistent comparison because people are including different things. They're weighting things differently in terms of values, but they also may be interpreting things very differently, which is an added source of variation. So you can't get back to the issues that need to be elaborated from the individual scores. You can have a structured discussion of the issues, and both prior committees identified virtually all of the issues beyond public health benefit and associated costs that you are now trying to put into a very complex scoring system. But those prior committees suggested that many of these issues were in fact secondary to public health benefit and associated costs, may be related to them. And I think your committee, after recommending this very complex scoring system, goes back to this is a decision support tool, and you have to have a set of discussions before you get to an ultimate set of priorities or a portfolio of priorities. So I circle back to the question, if you've generated all of these scores, how do you use them? They can't structure the discussion. Only a structured discussion of the list of issues can actually help you have a structured discussion. So National Vaccine Program Office is faced with the question on which the committee has not provided any guidance, which is who as individual users do we ask to complete this system? 1,000? 10,000? Experts? The public? Advocacy groups? A mix of the above? What mix of the above? After you've got 1,000 different scores, the National Vaccine Program Office is faced with the question of how do you aggregate these scores into something which gives you a ranked list of priorities. Do you then take the top 5 based upon average, median? What do you do with outliers? You will get some responses. Some users of the system may totally misinterpret what they're supposed to put into a particular box, so you'll get some outliers. Do you throw them out? Or do you say, that, well, they probably did think this or that? Do you include them? So I think there's a really complex problem which you haven't provided any advice to National Vaccine Program Office on, is who fills out this system to get scores, how you use this, how you aggregate the scores, and then circling back, what use of those scores when you've got them in actually setting priorities, since they contain very different information. The way that I read the system that you're proposing is that the top 5 or the top however many are the ones that should be priorities. That's against the general concept of a portfolio of priorities which satisfies the needs of a variety of public health constituencies. I just want to make 1 or 2 other comments based on experience. People have raised this question of data ad nauseum. The data is never going to be perfect. You just use what is there. It's going to be easier than it was 10, 20 years ago because there are a lot more disease burden studies have been done. So that, and as Chris said, that's an advantage. You may have to cover more diseases, but since the data is never going to be perfect, you use what you've got. As Joachim said, you use estimates, and if you're not happy with the estimates, you use extremes of the range to figure out if the variation in the estimates affects the final results. In terms of predictions of vaccine prospects, I think one of the things that is clear from both the 85-86 reports and the 2000 reports is that attempts to predict the probability and the timing of vaccine development beyond 6 years are very unreliable. So I think the idea of taking predictions out 20 years gets you into the realm not of vaccine development, but NIH's realm of the need to put more funding into basic research because there are scientific problems that impede vaccine development as such. People have also raised the possibility of using this sort of model excuse me, for looking at operational issues in implementation. It wasn't designed for that purpose. There are, in fact, many other models, both for looking at the benefits of vaccines being put into use and models for looking at other interventions. The Swiss Tropical Institute, the Global Forum for Health Research, have got lots of models in those areas, so I don't think it's important to extend the use in that area. As I was listening, and maybe I'm subject to listener bias, but I think most of the panelists that mentioned something as the most important consideration that they were looking at, or they looked at in their work, was the public health impact and the associated costs of achieving that public health impact. I think the scoring system loses sight of that, particularly in allowing the possibility that that isn't even included, or that that is put as a secondary consideration to many other things. I wanted to respond to Dr. Phelps's comment that multi-attribute scoring systems have improved in the last 20 years. Statistically, there may be new methods, but fundamentally the objections to multi-attribute scoring, ranking, utility theory, those objections have not been satisfactorily answered, in my opinion and the opinion of other people. The scores that are developed through the system hide important quantitative information, and secondly, they introduce into the system many, many points in which subjectivity affects the ultimate outcomes. Why is that bad? Because if you have subjective values affecting a system, you want to be able to identify what is the effect across the whole range of those subjective values, what is the effect on the ultimate scoring or decision making. And when you have at least 29 points in which subjective values start entering the system, or maybe given difference interpretation as well as difference in values, 29 to the power 2 different points of entry of subjective values, it's virtually impossible to conduct subjective analyses to see what the, to conduct sensitivity analyses to see what the effect of variations in those on the ultimate rankings produces. Based upon my experience at the IOM, at the Children's Vaccine Initiative and National Vaccine Program Office, I would estimate for NVPO that the cost of redoing the system of prioritization that was done for the first and second IOM reports would be in the region of 5 to 10 million. If this system of incorporating many, many individual scores is proceeded with, I would say that it's 10 million at a minimum and probably a lot higher. Two final comments, both from the book of Daniel Kanahan called Thinking Fast and Slow. I haven't been impressed, to be honest, with the way this meeting is structured. It is structured with the impression that this is not, this is just a stop on the way plowing forward with this particular system. And I think it is, I think it's important for the committee to not show listener bias. There are many comments that were made that are fundamental criticisms of the way that this system is currently designed. And secondly, I think Dr. Canahan looks very carefully at what is called the sunk cost fallacy, which is essentially throwing good money after bad. I'll let NVPO make that decision.
Thank you very much. This concludes our stakeholder meeting, and we'll see the committee members later this evening and then again tomorrow. Thanks.